Once again, dear viewers, you're watching ERi-TV. Welcome to this special edition of Open Mic. My guest for this evening is Professor Mohamed Yakub Janabi. He is a Tanzanian cardiologist and the current WHO Regional Director for Africa. Welcome to our program as you are visiting Eritrea.
Thank you very much.
Dear viewers, with over 30 years of experience in clinical medicine, health policy and health systems strengthening, his regional priorities include universal health coverage, non-communicable diseases, local pharmaceutical manufacturing and health security across Africa. He is currently visiting Eritrea, where he has met with ministers, government officials and health practitioners and toured the Azil Pharmaceutical Factory, the current referral hospital, the genomic sequencing center at the National Laboratory Center here in Eritrea, the Oroto Cardiac Center, as well as several other hospitals. Again, Professor, welcome to our program.
Thank you very much.
Okay, yeah, Your Excellency, you have met with ministers and other officials and toured the Azil Pharmaceutical Factory, the current referral hospital, the Oroto Cardiac Center, and several hospitals across Eritrea. What is your overall assessment of the country's health system strengths and the key challenges that remain?
Thank you for the good question. Yes, I arrived here on Friday and I had an opportunity straight away that very Friday to meet the Minister of Foreign Affairs, to meet the Minister of Health, and then to meet the Minister of Information before I went to Oroto Teaching Hospital, where I visited the cardiology, the heart center, and the neonatology, where the babies, this premature. Overall, I have to be honest, the last regional director came to this country 20 years ago. I have never had an opportunity to visit here. So it was kind of a pleasant surprise let me start with the hospital, because I'm a public health specialist and I'm a cardiology interventionist. It was a pleasant surprise to know that they are doing such major operations like holes in the heart, VSD we call them, ventricular septal defects. They do TOFU, and the blood vessels are placed wrongly when you are born. They deal with mitral, of course. Cardiology is not an easy thing, like other specialties, but to know that the kids are coming sick and then one day they are leaving the hospital breathing better, they start to turn pink, because with some of these diseases, kids turn blue because of lack of oxygen. I could see the enthusiasm of the staff there, how they look forward to make things even better. The cooperation which they are doing with the Italian team when they come. So it's a very commendable, because there's advanced stage of management of heart diseases when you start to treat, not conservatively, but with a surgical intervention with good results. The one thing which I noted there, I had an opportunity to train in a very advanced countries, in Japan, in the US, in Europe. But I could see there, with minimal equipment, people can improvise and do the surgeries successfully, because what a parent needs is not how much advanced equipment you have. What the parents need to see his or her baby breathing again properly, bringing back the childhood so the child can play with other kids, because normally these kids can't play much. They get tired because of some of the diseases. As I said earlier, you don't have enough oxygen, so you don't have enough energy, so you can't play, and they cry the whole night and they cannot sleep flat, because when they sleep sleep flat, the condition gets worse. Now they can get the normal sleep. So a very big up to the team there. And we shared, they have the details, one day interview them, what and how can WHO do, work together to take it now to the next level. With the ministers, they were very clear with the objective of the country, which is primary health care. They know the priorities this country needs. So our job as WHO and other partners is to take the priorities and see how we can work together with the government to push the agenda of health for all better.
Okay, you've also visited the Azel Pharmaceutical factory and the current referral hospital. What is your general impressions about that?
Let me start with Azel Pharmaceutical. Again, another, because we drove for almost 2 hours and a half, and I was just asking myself, oh, this is too far. Why the factory was not near Asmara? But when I arrived there, I understood. One, Karen is not, I had this imagination, maybe a very small place without infrastructure. The infrastructure is there, meaning the electricity is there, water is there. Of course, there are challenges, but there is water. When they were giving me a briefing that it's a joint venture, which first thing we as WHO really encouraged, the government cannot do 100%. So when they go with partnership, of course, the government has majority there. If my figures are correct, is 60% government and 60% Jordan. That's the only way to go forward in any country, not only Eritrea. Private government, private-public partnership is advocated everywhere. So I was impressed that 30% of the essential medicines and IV drips for Eritrea, they are coming from there. So the expert there, there was, I'll not forget the name of this gentleman called Simon, the manager of, he was very enthusiastic. Now, I think we discussed the challenges, which again, I think we can work together, but they're on the right direction. I think what I discussed with the Minister of Health, who we were together there, is now how to see that people outside Eritrea know that there are medicines, there are IV drips, which are manufactured within Africa, in Eritrea. WHO is one of the biggest purchaser of consumables like gloves, syringes, medicine when there are outbreaks. So there are certain things which I think we discuss with the government through Ministry of Health to adjust them or to make them better. And Eritrea could be one of the suppliers of medicine in the continent, because as you know, Africa imports 80% of its medicine and diagnostic, 100% of its vaccine. So countries, when we see member states country like Eritrea making that effort, I think is something to praise a lot and to make them reach the international level for exportation.
Professor, as a cardiologist, what is your assessment of the Orota Cardiac Center and Eritrea's capacity to manage cardiovascular disease?
Okay, let me not answer you directly. I'll go this way. My first question, I usually ask member states or I ask countries, should you allow people to get sick to this level, to need maybe a pacemaker or to need bypass surgeries. And when they hesitate, I say you just need to invest on primary health care. Because if I can prevent you in the primary health care, very few people will need to go to the tertiary. I'll give you an example of diabetes type 2. It takes up to 20 years sometimes, between 15 and 20 years, for your diabetes to spoil your heart. But what about if I had integrated diabetes care in primary health care, and then I pick diabetes before it causes complications? You will need very few such advanced centers like what I saw there. But on the other side, it's a very cost-effective investment, because if you have such centers, you don't need Eritreans to travel outside, which will cost you a lot of forex to transport your patient. So if you look it on both ways, I will continue to use your barefooted doctors. I'll continue to invest on universal health coverage, which primary health care is a backbone of your universal health coverage, to pick these diseases before they cause complications. Because you go to any country. I was a CEO of my country, National Hospital. If I look on the data, the number one cause of amputation of legs is diabetes. The number one cause of blindness is diabetes. If you look on kidney dialysis, I saw you there, the number one cause of dialysis is high blood pressure than diabetes. So the approach which WHO is advocating now to our member states, integrate these services of NCDs to the primary health care, so we can pick them very fast. Two, I look on the demography of Eritrea. 70% of the people of Eritrea live in the rural areas. If you look on the outbreaks of diseases in Africa, which last year we had 148, they start in the community and they end up in the community. So where should I invest? I will invest more in the community. Because I repeat, if I can pick all these diseases early, they will not need the complications which we see. If I can enhance, yesterday on our way back from Karin, my team and I interviewed one barefooted doctor along the way. If Eritrea can continue to invest on these doctors, what I saw in Karin Hospital, you have this room, they call it where pregnant mothers, I'll simplify, where pregnant mothers, if the barefooted doctor, maternity home, if the barefooted doctor picked that this mother might have a complicated labor, so they come and stay there. And the doctors will decide this mother can give normal delivery or can have cesarean section. So you have already helped to decrease your mortality, which yesterday they shared your maternal mortality. I was looking on the figures of 2000 and the figures of now. Of course, it's still high, but if you compare what this country 24, 25 years ago, the mortality was 700 plus. Today is 291. It means there is a direction which you can see. And Africa is very unfortunate. In many countries, the mortality is 800, 700. So investing on primary health care, I do repeat, is a saver for Eritrea and the entire Africa.
So, Professor, I want to ask you what impressed you the most about Eritrea's primary healthcare system, just like you've just been telling us about Eritrea's primary healthcare system. I want to know what your impressions are about it, and including its network of community health workers, such as the barefoot doctors and the community health workers in general.
It's promising. It just needs more training. It needs more manpower. Because, just for your information, by 2030, the world will have a deficit of 11 million health workers deficit gap. Africa will have 6 million gap. So that's why this afternoon, when I was discussing with His Excellency Haile Metsu, I think at the medical school there, we discussed a lot on training. We discussed a lot to invest more on training, so that once you have skilled people in your country, it means quality skilled school. I was very impressed for him. He told me, R&D, it's not just to increase the number, but quality, which is true, because once the quality of trainees and they become qualified in different specialties, it means the safety of the patient. And this is how people save lives.
Professor, again, as you are well aware, Eritrea provides free healthcare to all citizens. What challenges does the country face in sustaining this model, and how can WHO assist?
Eritrea's model of largely free or highly subsidized healthcare is rooted to a very strong primary healthcare and equity principles. So it's a very notable achievement. However, sustaining any free or subsidized, highly subsidized, usually presents with structural challenges, financial challenges, and system level challenges. So I think in order to sustain it, one, I think the government has to work on expanding the physical space and domestic financing, because if you want to maintain it, it means you have to sustain it. If you have to sustain it, you need to have a very stable financing process. Now, whether it will be by collecting taxes and subsidizing the health budget, whether it will be increasing the health budget, so its sustainability will really depend on this. The other thing is to try to minimize out of pocket, because if the patient go to the hospital and let's say they don't get the medicines, what will they do? They will go either straight to the pharmacy or go. I've just been here for 3 days, so I'm not sure how much private practice is here, but other countries, they have a problem, because now patients start to leave the public, go to seek treatment either outside the country or... The third thing, in order to sustain free treatment or highly subsidized like here, you need to have the workforce. Really, so you have, if you have a shortage of health workers, then sustaining it and it will be very difficult. And I think it's very important to retain the staff. You need, I think the government needs to do kind of remuneration. There are countries where health workers are subsidized on the accommodation. The government says, okay, we are going to give percentage X for accommodation, or build the houses for the health workers. This is the only way you can retain them, because if you can't retain them, if they leave, so even if treatment is free, but you need doctors, you need nurses to provide that. The other thing which the country really needs to sustain is to continue to improve infrastructure and supply constraint. Make sure that the medical staff get all the equipments which they need, because I can come to the hospital, the doctor knows the diagnosis, that he knows the treatment, but if the equipment is not there to proceed to the next stage, let's say to do surgery or what, so you need that. Eritrea is faced, like many developing countries, with two. Still there is an infectious diseases, tuberculosis, malaria, and you have a rising number now of non-communicable diseases, heart diseases, diabetes. Africa today, 32%, no, 33% almost, people are either overweight or obese. And so it will increase the cost. You know, it's very easy, let's say somebody who has got malaria, you cannot compare the cost of treating a malaria patient, it's just simple malaria, and a patient with heart diseases or kidney diseases. So I see you, if I think the government has also to invest on preventing. Of course, the other things. So how can things like governance, that one, what I saw from the DGs, the governance is there. They might just need, as I said earlier, need more workforce. So how can WHO? WHO we can support by doing what we call it very strategic, systemic wide. We can strengthen just by giving consultation to the Ministry of Health, how to strengthen health financing, support development of sustainable health financing strategies like increased domestic resource mobilization, smart spending, where should the money be spent, innovative financing, you can pool funds, you can earmark taxes. I don't have to mention a country, but there's a country which I visited. Every liter of fuel you buy, petrol, 10 cents goes to the Ministry of Health. There are countries, the small island development states, the Mauritius and others, they've introduced tobacco taxation. They've introduced alcohol taxation for health. They've introduced all the sugary stuff like cakes, biscuits and everything. So they collect the tax, they call it health taxation, and increase domestic financing in health. So this one we can do. We can work with the country to health workforce development by expanding training, by finding way to retain your workers, task shifting policies we call them, support scaling up your barefooted doctors. We can join the government to train more doctors, provide technical assistance on workforce planning. I was with His Excellency Dr. Haile today, that you just don't increase the number of intake of students. You strategize. We want nurses. So I increase the number of nurses, I reduce the number of, let's say, doctors. I strategize. I was telling His Excellency Dr. Haile, the country has to start to think of bioengineers. You are having a lot of heavy, standard, high quality equipment. Who is going to repair them? Who is going to do service to them? So I think some of the things we brainstorm with officials I've met, these specialties have to be thought. Where you have fewer doctors, there's something called clinical nurses. They are allowed to prescribe certain number of medicine, so you don't have a big demand, especially in the community today, to have doctors everywhere. They can manage simple febrile condition. WHO can work with the government to improve service delivery and quality by strengthening your primary health care. We can help in advising the supply chain. Yes, you have things in Asmara. How can it reach somebody who is in Eritrea but near the border of Sudan? So, because supply chain, you can have everything here, but how do they reach those hard-to-reach areas, people who are living in the mountain areas. But the most important, which we discussed yesterday, how can you govern your data? Because in order to solve any problem, you need to have a very good database. How can we improve together to digitalize health? Because once you digitalize, it's first that human error, because I saw some areas where the things were still done in manual. We can digitalize, and WHO is good on that to do. So I believe with working together with the WHO, with all the information we have, because government has to be provided with latest information, what is going on, like the NCDs, we can provide the global data, we can provide African data. So it will improve government to plan, okay, this is a problem which is coming. I met partners today, and I think also partner coordination following the government policy. So the main takeaway, if I can summarize for you, so that the free healthcare model which I've seen here is equity driven, that nobody should be left behind. Very politically committed, because I had the head of state himself, but those constraints which I mentioned to make it sustainable, we have to shift. I usually, this word I try to avoid. It's not about free care. It's sustainable financing the universal health coverage. This is a correct word. And prioritize efficiency, targeted investments, and so leverage WHO can leverage this by technical assistance. Yesterday, when I saw all these PCR machines, sequencing machines, which have got the capacity of diagnosing, putting a correct diagnosis of bacteria, viruses, this is what I call preparedness. Because apart from the screening at the airport, which is done, the country has to have the capacity to make the correct diagnosis. So that capacity, I saw it there. There are things here and there. We have discussed some technical things. We are going to work with the government. But those basic things to make really an advanced diagnosis is there. Of course, there's a lot of room to advance. There are still some samples which are taken out of the country. But these are super specific tests. But the process, the country is already online. So I think with more investment on health, health has never been a cost. Health is an investment which I can't say in a long run, it pays back. Because if you have a healthy community, if you have a healthy population, meaning your people are going to be more productive. I was very impressed we didn't touch this in our initial stage. Eritrea has got 98% immunization coverage, vaccination. That's, you see those in developed countries, because even if you are 85, it's not good to prevent anyone, because WHO's cutoff, it's around 90, but you are better off when you are 95. The latest figures which were presented to me, and they are coming from UN agencies like WHO, is 98%. So I do repeat, investment on health is not a cost. If you look on a long run, it plays part in the economy, in the development of any country which invests more on it. And let me finish that example. I usually give example of the process which Japan took. Japan started thinking, discussing about universal health coverage in 1926. By 1961, Japan was 100% universal health coverage. And you know the outcome. They've got the longest lifespan in this world. So if you want to live long, just move to Japan.
Your Excellency, your vision emphasizes regional and global partnership to address Africa's shared health challenges. Following your meetings with Eritrean ministers and officials, what concrete opportunities do you see for Eritrea to collaborate more deeply with the broader African region, particularly in areas like specialized training or research and innovation?
We really discuss in length with Honorable Minister. I was with her yesterday the whole day when we visited Azahel factory. Again, today we went to do a summary of my trip. So there are certain areas we have agreed to strengthen, and first is to strengthen the healthcare system. That's the most important thing. With a very resilient healthcare system, the country can stand the shocks. The country, even if there's an outbreak, they can still deal with the outbreak and continue with the normal services. This is what we call a very resilient healthcare system. We agreed that we should work together more on training so that we can increase the workforce. We have agreed to prioritize preparedness. It's always more effective to prepare when you don't have an outbreak than to wait for an outbreak to come and then you'll go into panic state. So we discuss on that area. And I've seen its usefulness. We discussed this afternoon with His Excellency Dr. Haile that we should work, WHO and the School of Medicine, to have simulation exercises with the nurses. What happens if somebody comes in an accident? How do you do CPR? How do you do in case of emergency, somebody's bleeding? We can train, we can contribute on training, because an area which sometimes is forgotten, and I was very happy to hear His Excellency Dr. Haile talking about it. People don't die on the operation table. People die in ICU if you don't have good ICU staff, from the specialists to the nurses. People don't die on the table during operation. People die in the ward, because if you don't have very good trained nurses, when the instruction is to give injection 3 times a day, 8 hours apart, it has to be that way. And that way can only be not only with discipline, but with training. I've seen kids in the hospital, in my hospital back home, getting amputation because the nurse put a cannula to this tiny baby in a wrong place, and then gangrene occurred. We had to amputate a finger or the entire foot. I entered 2 neonatal units here in Orotu, and yesterday. You really need to have very skilled, because the baby is 800 gram, 900 gram. They fit in this palm. These babies, everything is immature. The lungs are immature, the heart is immature, the liver is immature. So they are very delicate. But with skilled people, you can take this baby from 800 grams to 1.5 kilo to 2 kilos, and then give him or her a chance to continue to grow like anybody else. So this transfer of skills, we have discussed it very seriously with the ministry, with the DGs, we have agreed to, with the capacity which I've seen yesterday in your factory in Axel, we have agreed to start the process so that Eritrea can have maturity level 2 and then go to maturity level 3. It's a benchmarking which was started, I hear, in 2017, but somehow in the middle it stopped. It's one thing which I'm going away. I've talked with my country office here. With the infrastructure which you have here, it will not take you long to get that maturity level. And it's very important for Eritrea because the maturity level 2 and 3 tells the quality of products which are coming from that factory. So with your partnership with Jordan, other players, Egypt is maturity level 3, Tanzania is maturity level 3. These are very close to you. I think if Eritrea uses the platform of East Africa, and these countries have gone through this process, it will be easy to cross-border information. And WHO, we are here, we can bring an expert here who can sit with the team, see where you need, for example, one of the criteria, let's say you need to have 10 pharmacists in this area so that you can produce. And for example, if you have 8, it means you just need to work to get 2. So they've got a lot of criteria, but it's all for the safety of the patient, all for the safety of the population. These are products which people take them, whether injectable or through mouth, and we know how many people get complication. It will help the country to avoid or to prevent antimicrobial resistance, which kills 5 million people every year in this world. So I think I'm living with very concrete picture with what are the priorities of Eritrea. How can we work with the government to not leave any Eritrean behind, even those living in hard-to-reach areas.
Okay, Professor, any final messages you'd like to leave to Eritrea before your departure tonight?
Thank you for hospitality, for hosting me for 4 days here and sharing without hiding things openly. I don't take that for granted, because if member states don't open up, there is no way WHO can succeed. But the 4 days, all the ministers I met, His Excellency Dr. Haile today, the people in the hospitals, directors of the hospitals, they were open. Where they've succeeded much, they told me. Where they think we can work together, they told me.
Professor, thank you so much for your time that you've dedicated to share this floor of Open Mic here with me tonight. Dear viewers, that was Professor Mohamed Yakub Janabi, the WHO Regional Director for Africa.
Thank you.
That wraps up this week's Open Mic. It is good night from me.